So, here is session 3, where we are going to discuss priorities and how you're going to plan or anticipate prioritization questions on the NCLEX. Okay, we're going to be using a mnemonic that I've developed in order to help us with deciphering or thinking through a prioritization question. Okay, but first, let's quickly talk about how these questions are structured so that we can get a sense of when you're working with a prioritization question. And those are probably going to make up a good majority of the questions that you're going to get at the end of your test, right? When things start getting tougher and they start becoming higher quality questions. Okay. So these are the ones you really want to master um, to really pass this test. Okay. So all prioritization questions come with a measurable change in the patient's status. Okay. You're going to be asking yourself, what's going on with this patient? How is this patient progressing in their disease process? Which is why when we're studying, we're going to be focusing in on specific disease processes. Here's where you're going to ask yourself, is the scenario being described to me normal for this disease process? Hmm? Or is the finding that they're trying to bring to my attention an unexpected finding, some kind of critical change in status that would warrant me as the LPN or the RN to make a decision about next proper actions? Okay, sometimes that next action involves notifying a provider. Other times that next proper action involves a nursing intervention. Okay, so but first you have to realize when there's a problem emerging. All right, and also an important reason for you to master those disease process signs and symptoms so you can know when we have an exacerbation or a change in status. Okay, acute beats chronic, ABC. Okay, acute beats chronic on the NCLEX. Often you have patients who have these long term or chronic disorders or diseases, like, for example, diabetes. Okay, diabetes management is going to be lifelong management, right? You don't just stop having diabetes problems. All the endocrine problems work like that, right? You're going to be taking insulin for the rest of your life if you're type 1 diabetic. Okay, acute beats chronic comes into play when that diabetic goes into, for example, diabetic ketoacidosis, okay? Or HHNK for the type 2s, but we'll talk more about that when we get to endocrine. All right, but the acute disease processes beat out those chronic symptoms that you might see in a patient who's been dealing with the disease long term. Congestive heart failure, that's another disease where the chronicity, all right, is kind of one upped by acute exacerbations, meaning this patient who always is struggling with hypertension, perhaps, or maybe even a little shortness of breath, right? Might be, well, maybe not shortness of breath as much. That would kind of define an acute exacerbation because maybe they're taking on peripheral fluid and they're actually in the periphery needing to be diuresed. All right. So chronicity tends to beat out acute problems. Okay, unstable beats out stable. All right, meaning the patients who are stable, and what do stable patients look like? Do they tend to have stable vital signs? Yes, they do. All right, so vital signs start there. When NCLEX lets you know that a patient is like losing their um stability, right? They're going to tell you that the vital signs are off. That's your first indication. So look to the vital signs. Is the patient experiencing hypotension? What about hypertension, like at a critical level? Generally speaking, when a patient's having an exacerbation with the blood pressures, we're looking for the super high highs, right? Or hypotension, all right? Which doesn't have to be super low, but you definitely use that as a way to indicate instability. All right, so unstable beats stable. Fresh post-op, all right, or 12 hours within a surgery is much more unstable than your other patients, all right? Your fresh post-op patients are way more unstable than your other patients. Watch out for the questions looking for the healthiest patient, meaning they're going to be those questions where you are doing discharge, right? You're thinking through a disaster, or you're thinking through a big, large mass casualty event that may have happened out in the community, and they're having to maybe clear the hospital or take that so that it doesn't go on diversion, right? So they can take in a bunch of casualties. Okay. Well, that as if you're the RN having to plan or manage room assignment, then you're going to want to know who the patients most ready for discharge are, right? So we're looking for the healthiest patients. So be careful. Prioritization sometimes look like those questions where you as the nurse will have to determine who you're going to see first because your acute exacerbations are require attention. Maybe it's pain, maybe it's shortness of breath, maybe it's bleeding, it could be anything, right? Where you need to take a look at those patients before the others, right? But then it could also be these patients like the diversion patients or room assignment patients where you're going to have to look out for the ones that are the healthiest, all right? And the ones that you will discharge first so that you can get those casualties in. All right, so how are we going to figure out the priority diseases? Right? So that we can figure out, or the priority disease processes, so that we can figure out who the priority patients will be. All right. We don't just use ABCs anymore: airway, breathing, circulation. Now, I want you guys to consider using care plans. It's a mnemonic that is more nuanced for the different kinds of priority diseases that show up on the NCLEX, okay? Because not all priority questions involve shortness of breath, right? Or bleeding or hemorrhaging, right? Or even issues around losing airway. Although I will say there is nothing more important than airway. Okay. Nothing more important than airway. So here is the mnemonic. I have a little graphic here to kind of give you a sense of the big bold letters on the left hand side that are involved in this mnemonic. Okay. Care plan. CAREPLANS. All right. So let's start with C. C is for cerebral. I'm going to break down that tiny writing that you see there on the left and give you a sense of the words that will describe each disease process so that you can begin to build these connection words, so that when you see them in the NCLEX, you'll go, okay, that's a priority because it's related to these trigger terms, okay, these key terms that will hopefully trigger you to think priority, got to do something now, okay? Let us start with cardiac. Let's first quickly go through each of the letters and what they stand for, and then we'll go through each one. First, C is for cardiac and cerebral. So it's going to involve the heart and the brain. A, the little image here shows airway or the lungs. Airway specifically involves this particular trachea, right, as it leads out to the bronchioles. However, the lungs are what's giving us the air, so I include that entire graphic there in airway. The R is for renal. All right, renal stands for kidneys, and we're going to talk a little bit about those emergencies connected to the kidneys. All right, E is for electrolytes, because there are electrolytes of choice that come up on the NCLEX, and I want you to know what they are. All right, and I want you to know how to associate that particular electrolyte with a particular problem, or type of problem or disease process. P is for peritonitis or abdominal. Okay. Um, yeah, there's a whole series of key terms that will connect you with this critical emerging crisis. Lethargy. All right, we're going to talk about patients who you don't want to see being lethargic. Okay, we're going to take our time with that. Altered mental status is what the A is for in care plans. All right, there's a lot there that we need to talk about. The N is for newborn, but I also want you to think maternity OB as well, right? So we're going to talk all things newborn, maternity, and OB, and we're going to break that down in its own mini lecture, all right, towards the end of our time together. And then finally, the S in care plans is for shock, all right, because there are multiple types of shock on the NCLEX, and we're going to have to talk about what they look like and how you will not be the person who misses those signs and symptoms. All right. Okay, let's start with the C in care plan. This is for cardiac and cerebral. All right. So here are some key terms. I'm just going to quickly burn through these terms, but I want them to burn into your brain. All right. Because when you see these key terms, I want you to think cardiac and cerebral issues. All right. It's really like neurological can go along with cerebral. All right. But I'm trying to get you to think C for the brain, cerebral, because there are some, key emergencies that arise that aren't always cardiac in nature, but are really critical to the neurology. All right. So I want to include them and group them all in here with cardiac because two, the heart has a brain, and there are neurological or electrical impulses that are connected both in the heart and in the brain. So I'm going to group them all together. Critically important. You need both. They're like important organs, number one and two. Brain being most important, number one, and then heart coming right behind. Okay, so myocardial infarction. Do you know what it looks like? Do you know how those signs and symptoms uh, present? Okay. Now, if you don't, you need to spend a significant amount of time making sure that you do, because NCLEX loves cardiac issues. All right. They love for you to demonstrate some mastery in all things cardiac. Why? Because it's the number one killer of men. All right. It's the number one killer of men. So if you don't know what causes problems in most of our patients in our country, right? In all countries, though, actually, if I'm honest, then you're more likely to experience a medication error or an error in clinical judgment when you should be sounding the alarm or letting providers know that there's an emergent crisis happening with your patient, right? Sometimes the signs are subtle. Okay, so do you know how to see an MI coming on? We'll talk more about it when we get to that mini lecture. EKG, dysrhythmias. Is your patient experiencing a fib, a flutter, VFib? Oh, God forbid. If the patient's going through a certain dysrhythmia, do you recognize it enough to know that this is a crisis arrhythmia, or if this is an arrhythmia that can be treated with medications after, letting the team know what your findings are there when you read the EKG strips? We're going to talk to you later on about the 8 EKG strips that you need to know for the NCLEX. All right, diaphoresis. Now, diaphoresis is a real sign of cardiogenic compromise. It just is, or I'll say cardiogenic compromise is what diaphoresis is. It shows up in shock. It shows up in myocardial infarction. Be concerned when you see a patient sweating profusely, okay? Associate that with cardiac stuff. Fluid deficit, same, okay? Dehydration is a cardiac issue, right? Because it leads to hypotension, which is a cardiac issue, all right? And it will also lead to shock. Fluid overload, that's a cardiac issue, all right? The patient's going to need to be diuresed. They're going to have peripheral edema. They might even have pulmonary edema, okay? That's a pulmonary issue, but it's also a cardiac issue, right? What are we going to do? Hold the bolus. We're not going to give them a bolus. We're going to hold the bolus. All right, stroke. Stroke is a cerebral thing, okay? Stroke can come in a hemorrhagic version. It can come in the ischemic version, right? Do you know the difference in those terms? Hemorrhagic versus ischemic, all right? Ischemic tends to talk about a blockage, right? Perhaps from atherosclerosis, where all this cholesterol buildup has happened and you have this plaque that forms inside the circular lining of the blood vessels, the small, tiny micro vessels that line the brain, right? And then occlude them, causing an ischemic brain attack or stroke, right? Well, that's not the same as a hemorrhage or an aneurysm or a burst of a vessel from high blood pressure. All right. So either one of those requires certain treatment. And I promise we will talk about that in the mini lectures to come. Seizures, okay, are cerebral events. Okay. They are actually high intensity um critical events. Okay. So seizures, do you know when they're coming on? Do you know what medications we're using to treat them? Do you know about the seizure protocol? All right. Increased ICP. ICP stands for increased intracranial pressure. So when you have an increased ICP, you have some threats that are immediate that you need to address. Projectile vomiting. All right. Is that a major deal or is that a small thing? No, it's a major deal. All right. And it's generally a sign of increased ICP. So can you connect those? Laminectomy is more of a neurological thing, but do you know the neuro checks? Do you know which parts of the spine innervate the functions of the body? Do you know how to assess that? All right. Do you know lumbar spine is connected with which bodily functions, right? Thoracic spine a- associated with which bodily functions. Important. You need to know, right? Because when a person's having a laminectomy, right, or that surgery to decompress the spinal the discs of the spinal column, right, to decompress them, that might require certain assessments that you as a nurse will do on that patient to assure that they maintain sensation or function of those nerves n- um, where those nerves end, those organs, those destinations for those nerves. Okay, so important neurological assessment stuff that you need to know. All right, so that's the C. Important, important, important. Let's move on to A. All right, A stands for airway. Now, it comes second in order, but it is kind of first in importance. So know that the care plan's mnemonic is not in the order of importance because airway is most important, okay? Airway, airway, airway. And I'm going to tell you that early and often in this course. I'm going to make sure you have an understanding that there is nothing more important than airway. All right? Airway terms would be SOB, shortness of breath. Okay. We see shortness of breath, get to doing something. All right. Usually you're going to oxygenate your patient as a priority, meaning the most important thing that you do for them. Although you, of course, know the first thing you're going to do in a patient who might be reclining in a hospital bed would be to put them in Fowler's, right? Put them in semi-Fowler's position so that once you apply the airway, I'm sorry, the oxygen by nasal cannula, that it actually has a function, that it will actually be able to reach the alveoli of the lungs and give that patient a benefit. Okay. So there's first and then there's priority. Remember that. All right. Respiratory. That's a term. A respiratory imbalance, acid base imbalance, like respiratory acidosis or respiratory alkalosis. Those are terms that get connected with airway, acid base imbalances in general, and having to have ABGs or arterial blood gases drawn, airway stuff. All right. Generally, we're trying to see if we need to put this patient on a ventilator. If we put that patient on a ventilator, it's because we have taken ABGs and determined that their blood gases are completely out of normal limits or outside of normal limits. Do you know how the acid base imbalances break down? All right, there is a little mini lecture that I have about that as well, because NCLEX totally wants you to understand when your patient is in acidosis and then subsequently know what you might do for that patient. Okay, what you might do. So knowing the conditions and knowing the initial nursing interventions, key for the NCLEX, okay? Asthma, key term. All right, naturally. Patient has asthma, you're going to think about their airway. Anaphylaxis. Is your patient allergic to bee stings? Do they get hives on the inner lining of their trachea? All right, well, that's going to create an airway issue. Is your patient at risk for pulmonary embolism? Okay. Do you know the risk factors for APE? All right. I have DVT there. Yeah, that's one of the risk factors. A DVT or a deep vein thrombosis is in the vein and it's deep in the vein and it's a thrombus. All right. And a thrombus is a blood clot. A thrombus on the move is an embolism. And if that thrombus in the vein on the move towards where do veins go? Towards the lungs, all right, to become reoxygenized. Then if it gets stuck, this blood clot in the lungs, you now have a pulmonary embolism. It can be a sudden and immediate and very shocking, pulseless um, scenario, okay, where the patient immediately feels a sense of impending doom and then they fall. Okay. You do not want to be the nurse who didn't think about the patient at high risk for a PE. Do you know who those patients are? Right? The patients who are at high risk for DVTs. And do you know who those patients are? Right? Those patients are going to be the patients who have immobility issues, for one thing, but then also patients who have issues with hypercoagulation. So, if they are having problems with clotting factors because maybe they're pregnant, or perhaps they've been in a surgery, or perhaps they just had a myocardial infarction, right? There are a lot of things that could make the blood viscous. Atherosclerosis will do that. Right? Epiglottitis, that's an airway problem, all right? Mostly for your pediatric patients. Asthma, oh, I thought it's so nice. I mentioned it twice, all right? So asthma is another key airway issue. Using accessory muscles to breathe, all right? That's a term. I have one that's not here. Grunting, all right? Retractions, all right? They tend to go with using accessory muscles to breathe. Those are bad assessment findings. Bad, bad, bad. If you find them in your pediatric patients, they're probably in acute respiratory distress. You could find them in your COPD patients and your emphysema patients as well. All right. Using accessory muscles to breathe are not a good thing. So, can you pick up on those subtle terms and those key words, those assessment findings that indicate to that algorithm on the NCLEX that you understand this is a good thing, a bad thing, or a status change? All right. Status changes, guys. This is what it's all about. Neck edema, airway issue. Okay. Thyroidectomy will bring a neck edema, right? Meaning edema of the soft tissues that surround the trachea, right? They can become airway problems. That's why post thyroidectomy, we want to put our patients in certain positions so that they are draining and they're not building up exudate or swelling or edema in one area, right? And that could put a threat to that patient. All right, drooling with stridor. If you think drooling, oh, that's not so bad. They say the patient's only 18 months. Maybe they're teething. All right. If you see stridor, there's much more going on here. Okay. Much more going on here. Stridor is a bad word for airway. So if you don't know what it means, look it up. All right. Make sure you understand what stridor is. And I'll just mention that it's audible without the stethoscope. And I'll also mention it's not wheezing. Okay. Don't just make it wheezing. All right. It's a different process happening, right, than wheezing. So drooling with stridor, do you know to get upset? Do you know to get excited? Do you know to move in a way that shows the NCLEX that this isn't a small thing? All right. Well, these are some of the terms that'll help you know when to treat something like a priority. And here's this last term, anxiety. Anxiety doesn't seem like such a bad word, does it? Right? A lot of us have it. It's a lot of generalized anxiety going on out there in the world. But when NCLEX chooses to use the word anxiety, sense of impending doom, or any other type of term that uh, implies that this patient is extremely nervous, okay, you've got to take it seriously when you see it paired with these other terms indicating airway problems, all right? Because usually there's not a lot of time left before this patient goes bad. I mean, like into critical crisis where you need to call a code blue, or, maybe the patient's having a PE, all right? Or, there's a lot of problems when don't take anxiety as a small thing, all right, when combined with airway. That's my point.